Alright, for this third video in our shock series, we're going to talk about treatment, of which there are 4 phases. In the first one, salvage, our main goal is to get the blood pressure up and get the cardiac output up in order to ensure survival. The next phase is optimization, and here we want to optimize fluid status and oxygen availability to the cells. So once we've optimized these two things, then we move on to the stabilization phase, where we're just trying to prevent organ dysfunction by organ support. It's not really oxygen delivery so much, but more organ support. So if the kidney's not working very well, then you can put the patient on dialysis until it starts working better. And then finally, what you need to do is de-escalation, and that's when you wean the patient from all support and get them to doing stuff on their own again. And it's these first and maybe the second phase that we're going to be worried about in the emergency department. So let's get into some of the details. So let's talk about the initial resuscitation. And traditionally in emergency medicine, we have labeled those as the ABCs. And if you break this down to our oxygen delivery equation from before, airway and breathing can be responsible for improving oxygen content. And circulation is, of course, cardiac output. So airway is important. It's very important to get good ventilation because we want to get oxygenation improved and optimized using whatever method that works. And that may require intubation, or it may just require non-invasive ventilation. And by putting someone on the ventilator, you could actually decrease the work of breathing because the respiratory muscles have a high metabolic demand. And so we know that we want to improve oxygen delivery to the other tissues. If the respiratory muscles are taking up less of it because they don't have to do the work, then great. And circulation, we're going to deal with using IV fluids and vasoactive agents. Another way to organize this is to organize it using the VIP rule. So ventilation means, you get the patient some oxygen somehow, and that could be either by a non-rebreather mask, non-invasive ventilation, or invasive ventilation like an endotracheal tube, intubation. Infuse is to give the patient some fluids, IV fluids, usually crystalloid, but maybe that's blood. And then pressors, of course, refers to the vasoactive agents that we'd want to give. So those tend to be pressors. So let's talk about each one of these real quickly. So V is ventilate. And you'll need to do whatever it takes to get this person oxygen. And the first thing that you'll start with probably is a nasal cannula, giving them 100% by nasal cannula. And if that doesn't work, we move up to a non-rebreather mask. Then non-invasive ventilation, things like BiPAP and CPAP. And finally, you put them on a ventilator with invasive ventilation and knock them out, and you take away their work of breathing with intubation. Now, a quick word about ventilation. These two methods here are positive pressure ventilation, meaning we are shoving air down their throat. And that has some implications. So with positive pressure ventilation, we're shoving air down into the lungs, and then that causes the intrathoracic pressure to be positive because we've got all this pressure building up in here, as opposed to the negative pressure system that normally exists. And the thing that happens is as the pressure builds up in the chest, it puts pressure on the vena cava, and so you will have decreased return to the heart, decreased preload, because there's more pressure in here. It's harder for blood to get up into there. You could even put pressure on the heart, making that even less. So with less blood going into the heart, you're going to be decreasing cardiac output. So it's just something to keep in mind, that positive pressure ventilation can hurt us, because remember, cardiac output was one of our bad things in shock. So now let's move over to the infuse part of our salvage treatment. So if you'll remember our Frank-Starling curve, in which we have volume on one axis and cardiac output on another, and the graph looked something like this. Our aim is to aim for this part here, the flat part of the curve. All right, so we're going to aim for the plateau. The plateau is the portion where the cardiac output has pretty much reached the maximum that it's going to get. So if you're over here in this section here, right over here, maybe you've only given a certain amount of volume, we have some improvement of cardiac output we can do by giving more volume. So we give a little bit more volume, hey, hooray, cardiac output went up. Give a little more volume, hooray, cardiac output went up. Give a little more volume, cardiac output has not gone up. Give more volume, cardiac output has not gone up. That's when we know we've given enough volume, when we aim for this plateau. So how do we know that we're at the plateau? Well, we could just try giving a bolus. Give a small 500cc bolus and see if there's any change in the blood pressure. It's a crude way of doing it, but you know what? It works. Another way to do that is to give a fluid bolus that's already in the body. You can just raise the patient's legs up, which is like giving a 200 to 300cc bolus. And then you should see an improvement in cardiac output or pulse pressure. So what we're really doing is we are trying to judge for fluid responsiveness. To see that if we're over here, if we are fluid responsive, we know we got some more work to go to aim for the plateau. There are, of course, other methods you can check. On ultrasound, you could check the compressibility of the inferior vena cava. Or you could put in a central line and check the central venous pressure to see that that's high enough. Some people say that number should be 8. But really, our goal is we want to be off the fluid responsive part of the curve and get to the plateau. So does it make a difference what kind of fluid you give? Normal saline, lactated ringers, or blood? Well, of course, in hemorrhagic shock, the thing that the patient is losing is blood. And so you want to give them back blood. So we want to give enough blood that there's enough hemoglobin to circulate the oxygen around and keep the patient well perfused. They don't have to get back to their normal blood pressure, but they just have to be well perfused. Normal saline is the fluid that we often use, but in these people who are in shock, you could give large doses, which could actually cause hyperchloremic acidosis, and we know that these patients already are acidotic, and so you got to worry about worsening that by causing this acidosis. And so lactated ringers is thought not to have that problem. There are other fluids out there like plasma-lite, which is similar in that it will not cause that hyperchloremic acidosis. So now let's move on to pressors. So once we've reached the plateau and we are no longer fluid responsive, if the blood pressure is still low or perfusion is still lacking, giving more fluids is not going to do anything, so we need to do something different, and that's when we use the vasoactive agents. So on the plateau, we know that the tank is full, and so that's taken care of. Now we still may have other problems to deal with. We still may have our pump and our pipes problems. Now your pretty much go-to drug here is going to be norepinephrine. Except for some special cases, this is what we're going to use. So remember that we have beta receptors on the heart and alpha receptors on the blood vessels. Activation of beta will increase contractility and heart rate. Activation of alpha can increase vascular tone, but has the added effect of decreasing cardiac output and therefore decreasing tissue blood flow, and it could cause an increased amount of arrhythmias. So let's first look at the cardiogenic causes. So if the heart is not pumping properly, then you need an inotrope, something like milrinone or dobutamine. Of course, not all cardiogenic causes are going to respond to inotropes, like arrhythmias may actually be worsened. Valvular stenosis, you might be able to bridge them with dobutamine or something, but they're probably going to need some sort of surgery to fix that. Now let's move down here to the obstructive causes. Most of these are just going to need the obstruction to be fixed. But you can bridge them with norepinephrine until that happens. Pulmonary hypertension, you may get some luck with milrinone and oxygen. Now what about distributive shock? Well, for sepsis, norepinephrine might work well. If that doesn't work by itself, then you could add epinephrine to it as well, but norepi is your first line here. Neurogenic, again, you can bridge with norepi. Anaphylaxis is a special kind of shock. It needs epinephrine as its first line. And you'll, of course, treat it with whatever other things you need to give, like steroids and bronchodilators, but for the shock, epi is your drug of choice. And for adrenal insufficiency, of course, steroids is what you need to give to this person. So this is a really brief overview of the drugs that you can use for pressors. Norepi being the go-to drug, but then you give inotropes. And there are special cases like epinephrine and steroids in these. And remember, you only want to go to the vasopressors once the tank is full. If the tank isn't full, then you need to give fluids. Pick your fluid and give it until you hit that plateau. And then also you want to make sure that you maximize the oxygen delivery as well. And that's that for this super brief overview of shock. This is the third video in this 3-part series. Thank you, and have a good day. Bye-bye.